This is a conversation with Dr. Shan Siddiqi, psychiatrist and lecturer at Harvard School of Medicine. Dr. Siddiqui is one of the leading TMS researchers in the field of neuroimaging, and especially in taking our understanding of neural networks of neurology and neurosurgery and applying them to TMS treatment. In this interview, Dr. Siddiqui gives us an appreciation of just how solid the research is in TMS treatment of depression, such that it is now being considered as a subspecialty in medical education for psychiatry, neurology, and neurosurgery in the US. This will further validate TMS as such an integral part of mental health care. We also discuss some further exciting developments in the field relating to TMS's application in other areas of healthcare. Here is our conversation. Right, and thanks for joining me. I'm Dr. Trevor Brown, Academy Manager for Neurocare, and again, thanks to Neurocare for sponsoring this and allowing me to bring you for free the opportunity to speak to Dr. Shan Siddiqi today. Shan, you're a medical doctor. You're also Associate Professor of Psychiatry at Harvard Medical School. How are you going, Shan?
Good. Thank you for having me. It's so fun. Excited to be here.
Excellent. Look, first time we've actually spoken together, and we've been conversing a little bit. And one of the reasons I wanted to speak to you today was one of the latest publications and get your thoughts on that, and hopefully bring some awareness to people about accreditation and I guess how the field of neuromodulation is moving forward. But first, we're going to get to know you a little bit. We're going to chat about your education, some of your previous research, and then things you're working on, but really, it's that article that's titled "Towards Accredited Clinical Training in Brain Stimulation: Proceedings from the Brain Stimulation Subspecialty Summit." So, the field of neuromodulation brain stimulation is growing rapidly, and you're a big part of that, both in the clinical application and research publications. So, the field needs to keep up, right? Where there are all these publications every single day, 16, 20 publications every day. Nobody can keep up. So I'd love to do these chats with some of the authors, Shan, and it's great to have you on today. Um, so the intention of the Brain Stimulation Society Summit was to discuss what should be done in the US in terms of the clinical training across the US. And I guess that's as soon as something happens in the US, it spreads across the world. So it's really important to us. It's a complicated problem, and we hope to disentangle that a bit with you now, Shan. But first, Shan, tell me a little bit about yourself. Where'd you grow up? Your education, that sort of thing.
Yeah. I'm originally from Pakistan. I lived there till I was about 9, but so I had the opportunity to live in America as a young immigrant. So in two cultures. So, as you can hear, I think I talk mostly like an American, but if I'm speaking Urdu, I sound like a Pakistani. So I had the unique opportunity to sort of learn from both approaches. I went to college at the University of Missouri, which is close to where I grew up in St. Louis. And I went to med school in Australia, actually, in your neck of the woods, the University of Sydney. That was a fun 4 years. Before it was a nice opportunity to spend 4 years in a cool, interesting, fun place, and then without any long term commitments. After that, I came back home to St. Louis, and I was fortunate that it just so happens that the place that's best known for neuroimaging research happens to be in the same city where I grew up, at Washington University in St. Louis. So I don't know if I went there because I wanted to be a neuroimager or if I went there because I wanted an opportunity to hang out with my college friends again. Uh, but uh, uh, but I went to WashU, and that was where I learned neuroimaging. And it's a funny. I think it's a funny coincidence. I have the same conversation often with Nolan Williams, who you've probably heard of or spoken to or interviewed before. He grew up in Charleston, South Carolina, which happens to be a place that's known for brain stimulation. And if he hadn't grown up in Charleston, the field of brain stimulation would be very different. He's come up with a lot of great innovations that were only possible because of that unique training that he had. He wouldn't have had that unique training if it hadn't just been a coincidence that he came from Charleston. So I think this is the same thing with St. Louis for me, is that I happen to be from a place that happens to be really good at neuroimaging. Uh, it was a and then after residency, I came to Boston because I thought that was the best place to learn. image-guided brain stimulation. So the image guidance side I learned at WashU, but the brain stimulation side was kind of weak there. So I came to Boston to learn about that, and I've been here for the last 8 years or so. So what my original plan was actually to come here uh, and then move back to St. Louis after a year or two after doing a fellowship. Then I met my wife here. She didn't want to go to St. Louis, so that made that easier.
Yeah. Yeah. Oh, great. So most of your work at the moment, you're at Harvard, and you're doing a lot of neuroimaging, looking at transcranial magnetic stimulation primarily, and the different neural networks in the brain that are being activated, and different placements of the coil. What's some of the most recent TMS research that you've been involved in, and what have you found?
Yeah, so broadly, our uh, the approach in our research is to take the successes for brain stimulation that have occurred, find image-guided ways to sort of break it down, reverse engineer it, and then apply it to new things. Uh, so most people in the field now agree that TMS is a very effective treatment for major depression. Deep brain stimulation is a very effective treatment for Parkinson's disease, for essential tremor, and for epilepsy. These, and maybe for major depression, but definitely works for those other three things. Uh, and so what my research is mostly focused on is to take those things where we know that it works, uh, learn what we can about those uh, uh, those indications, and then translate it to other things. The way we did that is by finding that if you look at the effect of damaging a particular system in the brain, uh, when that causes a particular symptom, then stimulating the same system tends to relieve the same symptom. So, in other words, if brain damage to a specific circuit causes depression, then stimulating the same circuit in people without any brain damage can also relieve depression. It's an oversimplification, but it turns out it works. Breaking it and stimulating it do opposite things. Uh, and we validated that with depression, with Parkinson's, with tremor, with epilepsy, with all the different things where we know that brain stimulation works. And once we were convinced by that, we've now started applying it to other disorders like anxiety disorders, PTSD, schizophrenia, bipolar disorder, uh, functional neurological disorders, things where we don't quite know how to use brain stimulation yet. It's not yet widespread. Uh, and we're trying to apply these new techniques to figure out how to use it for these other disorders. So that's what I spend most of my time doing in various iterations, either uh, clinical trials of new indications, mapping circuits for new targets, working on biomarkers and other things like that. So different dimensions of that.
Fantastic. Well, I mean, I know personally, I've read a lot of your work, but I know the field looks at your work a lot, and along with Mike Fox, I think he's in your team there as well at Harvard, and Nolan you mentioned before, and you guys are really pushing the field forward, and allowing us to personalize and break new ground with TMS, which is a really fast moving field, and for that reason, I guess it was time to start to get an accreditation process for training in the US. And so it sort of follows that since it's really moved forward over the last 10-20 years, we needed to do that. Was that the impetus for you, or was there something else that triggered the Society for Brain Stimulation to start this accreditation process or publish this paper?
Yeah, I don't know if there was a specific impetus. It's been a gradual process over the years. So, for example, I've been leading this initiative along with Nolan Williams again. Nolan wrote an article about this when he was Uh, I think he was a senior resident. I was a junior resident at the time. He co-wrote this article with Joe Taylor and Mark George about the idea of standardized clinical training and residency in brain stimulation. I said, "Well, this is so cool. I love this idea. I think everybody should implement this." I took the article and I sent it to my training director and I said, "Hey, can we implement something like this in our training program?" And he got back to me and said, essentially, "You have no idea what it's like to build a training program. It's very difficult. And if I were to add new stuff to my training program, I have to subtract something existing from my training program. And right now, the training program is very carefully designed, so I can't just add more stuff to it." And I said, "Okay, yeah, that's a good point." Interesting talking to an experienced person. So ever since then, it's been on my mind is that when is this going to feel going to be far enough along such that we actually need a training program? That we that when go to a program director and say, "Hey, how do we implement this?" Instead of them saying it's not as important as some of the other things that we're learning, which was a very reasonable take at the time. They'll say, okay, this has gotten important enough, so I need all my trainees to learn it. And I did this not because I love brain stimulation, but because I love psychiatry. Psychiatry is something that I literally fell in love with when I was doing my psychiatry rotations in Sydney, and I fell in love with kind of the same way I fell in love with my wife, and it's the only two times I've made major decisions based on love. Uh, it, it, it's it, it was uh, it was something that I just knew was right for me. And as I was going through psychiatry training, it was obvious to me that this field has some fundamental problems that need to be improved upon. And again, because I love it so much, I want to work on improving those problems. I think some three of the most important problems in psychiatry are lack of standardized training across the whole field, not enough neuroscience in day-to-day practice, and inconsistency in clinical practice standards. And I thought that the best way to fix all those things, uh, we have to do something organic. There's not going to be an initiative like a study that just suddenly changes everything, or uh, uh, or or a center or an institute that suddenly changes everything. It has to be something that changes the culture fundamentally. And so I sat there and thought, well, what is it in neuroscience that's closest to tipping over into clinical translation? Uh, and if we can figure out how to push it over, take something in neuroscience, and just push it over the edge into clinical relevance, that'll force people to learn neuroscience as part of psychiatry training. And I think that'll solve all these problems on its own. And that's why I started studying image-guided brain stimulation, because I thought that was the thing in neuroscience that was closest to tipping over into clinical translation. So why I came to Boston, why I decided to work with Mike Fox, etc. Uh, and so after a few years of that, it started happening. It started tipping over, and I think you gave me too much credit for driving that change. I don't think I drove that change. I think, like I said, I just chose a field where the change was already happening, and just like I said, helped tip it over. And so uh, uh, after a few years of this, I started to notice every couple months I'm getting an email from a trainee saying, "Hey, how do I learn how to do what you do?" And I said every single time I'd respond to them, essentially say, "Well, all you have to do is do a few fellowships, start doing this stuff, and after about 10 or 15 years, you'll know stuff." And obviously, that's not the answer they're looking for, right? They want to be formally trained. Uh, and I'm not the only person who's had this experience. Many of my colleagues have had the same experience. Uh, and so then a serendipitous thing happened. Andy Horn, who is a DBS mapping expert, uh, emailed me and said, "Hey, Sean, there's this Harvard Radcliffe program that allows you to uh, sort of create bring together some of the world's leading experts on any given topic. They'll fund you to solve an important problem in the world." And he'd done one of these before on DBS, kind of showing DBS. And I said, "Oh, great, I'll apply for this." I applied for it, uh, and we got to the finalist round, but didn't end up getting selected. But in the process, and I think the reason why they didn't select us is because they prefer more theoretical things and less empirical, practical things. But in the process, I told a bunch of people that we were doing this. I go to conferences and say, "Hey, I'm hoping to get funding for this to host this thing, and I'd love for you to come." And every single person I talked to about this said, "I don't need funding. If you do this, I'll pay for it. I'll come. I'll pay for my own travel." Whatever it costs, like, don't worry about the funding, just do it. And I said, okay, well, clearly everybody wants it. 100%. I talked to 20, 30 people about this. Every single person said the same thing, that I will come and I don't care if it's funded or not. Uh, and so when we didn't get funded, I said, well, I have a plan. Like, I registered a plan for how we were going to do this as part of the funding application. I said, what if I just do it anyway, but unfunded? Uh, and So that's what we did. We invited 85 international experts from around the world to come to Boston and discuss, like, how are we going to build this into formal accredited subspecialty training. Of those 85 people, 55 actually showed up at their own expense, uh, and many others showed up via Zoom. And so that's when I realized, oh, well, I mean, I was inviting all these people. I'm you know I haven't been around for that long. This was in 2023, so I was 38 years old. I'm not one of the most experienced people in this field. So the fact that all these highly experienced, well-known people want to come at the invitation of a relatively young person to work on this problem made it obvious that we've hit a chord. Like we've struck something that people really care about. Uh, and so, uh, so all these people showed up, and I realized why they were showing up is because again they shared the vision, recognizing that not only do we need to standardize training in this field for subspecialists, but also by creating an accredited subspecialty, you bring legitimacy to something. Right now, in general psychiatry, to a lesser degree in neurology and neurosurgery, but definitely in psychiatry, it's still socially acceptable for a psychiatrist to say, "I don't believe in brain stimulation." Some psychiatrists will say that that, "Oh, does TMS really work? I don't know." I don't, that should not be a socially acceptable thing to say. It's so wrong that a psychiatrist should be embarrassed to say something like that. To express an opinion like that. It's like saying you don't believe in psychotherapy or that you don't believe in SSRIs. It's just the evidence is unambiguous. Of course, it works. Uh, and so uh, so I think what people were realizing is that when you accredit something, people can no longer ignore it. And I've found this when I'm interviewing medical students for residency, one of the things they want to know is what subspecialty training programs are available at your facility, because that the more programs are available, the more they think, okay, this is a robust, comprehensive opportunity for me to come learn from. So so like I said, my because my goal has been to again tip things over the edge. We've I think I thought this would be an initiative that helps us take brain stimulation and move it from I think that's somewhat at the fringe to something that's mainstream that everybody has to know about. Again, uh, I had to do a neuropsychiatry rotation in my residency, but I did not have to do a brain stimulation rotation. Why? Sorry, that wasn't meant to be a thumbs up. Why? It's because I think it's because neuropsychiatry is an accredited subspecialty and brain stimulation is not. So our program director said, well, if there's an accredited subspecialty out there, then all of our trainees should be aware of it. Uh, and that was the motivation behind it.
So, thanks for that background, Shan. That's a great overview of everything you've done. And I love the passion. You know, the passion you got for psychiatry and bringing brain stimulation in as a subspecialty. So, for those of us who don't know the education system in the US as well as you do, you've got your psychiatry training, and then you've got various subspecialties that can you can learn, and they're different at different universities. Um, but these subspecialties all have accredited training programs in order to become a subspecialty. They need this accredited training, do they?
It's to be taken seriously. Yeah, there are a lot of subspecialties that are unaccredited. And I take that back. Not necessarily. Some of them are taken seriously despite not being accredited. But yeah, if once you are accredited, then nobody can ignore that it's a legitimate subspecialty.
Okay, I understand. Great. And so you've got all these 55 experts from around the world who are really keen on seeing the value of this and wanting to go ahead and you know you've got everybody there. What did you talk about? How long did it take? What did you find that were the positives, the negatives? Because it must have been a real eye opener. You must have come across a few difficulties there.
Yeah, there were a lot of different opinions. Our initial goal was to take well, so it was 2 days. We had a schedule. Uh, our goal for the first day was to establish whether this is needed or not. So there was a set of discussions around like what are we talking about? What are we not talking about? What are the risks of establishing a specialty? For example, in the U.S., where we have private health insurance systems, there was a concern that if you establish a subspecialty, that insurance companies might use that as a barrier to reimbursement. They might say, we won't pay for a treatment unless the provider is subspecialized. So we had an insurance expert come in and talk to us about uh, is that a is that a how high of a risk is that? Because we have a tendency in medicine to worry that insurance will do something without fully understanding how the insurance actually works. Uh, Turns out there's no precedent for insurance withholding treatment uh, prescribed by an unaccredited practitioner, just because they're unaccredited. That there's And it actually turns out the opposite is more likely, is that when a subspecialty becomes accredited, it gets more representation towards insurance companies, and it makes the insurance company look good when they have more subspecialties in their coverage network. It allows them to charge higher prices for their premiums. It helps them maintain accreditation. So in fact, insurance companies are incentivized to have more subspecialists, thus improving reimbursement for the subspecialty. But that was a concern that people had. Another concern that people had was, are you going to make us start doing? Are you going to force everybody to become accredited? Are you going to force people to do fellowships, do training? So the clear answer to that was, we're not trying to redefine how people do what they're currently doing. Psychiatrists who want to learn psychiatry and then go do TMS, they're they can keep doing that. Or if a neurologist wants to learn movement disorders and do DBS for Parkinson's, they can keep doing that. We're not going to stop them. What we want to do is create an opportunity for people to cross train that doesn't currently exist. Uh, so not to change how people currently do things, but to create an opportunity to do something that people aren't currently able to do. For example, a TMS psychiatrist doing a couple months of cross training in DBS for movement disorders and epilepsy, uh, and also rotating in ECT and maybe ketamine, whatever else, in order to develop broad expertise in the principles of brain stimulation. One of the problems that led us to approach this also that I hadn't mentioned yet is the fact that psychiatry has developed broad knowledge base about TMS. Neurology and neurosurgery have developed broad knowledge bases about deep brain stimulation. And we don't learn from each other, even though a lot of the principles can translate. So we need a program that forces people from one side to learn from the other side so that we can. So one thing that Nolan says often, for example, is the reason why he expected that Saint would work, his high dose accelerated TMS protocol, is because the doses were still way lower than what they were using in DBS for Parkinson's disease. And so he said, well, I can crank up the dose by a lot, and I know that it's still safe because it's done in DBS all the time. And he could only think of that because he was also doing DBS for Parkinson's. He's also a neurologist. Uh, so, uh, so these are the kinds of questions we were debating for the course of the 2 days. Another big thing that we did on day one was brought a bunch of experts to give their perspective on whatever the most important thing is they're working on that will translate into clinical practice. The reason why I invited people to do that was because one of the most common objections that I used to hear from people about subspecialty training is, oh, you don't need an accredited subspecialty training in order to learn this. All you have to do is learn the stuff that I do. So come to a fellowship with me, and I'll teach you how to think like I think. So what I wanted to illustrate was that when I bring 30 people to present on this stuff, we didn't have time for everybody to present. But if 30 people give 10-minute presentations on how this should work, you're going to get 40 different opinions on how to do it. And sure enough, that's what happened. Is that everybody had a different way that they thought was the coolest new thing in this field, which illustrated that you can't just learn the field by going and learning from one person. There needs to be a standardized uh, uh, approach to it. So another important thing that we wanted to settle was what to call it. Some people wanted to call this interventional psychiatry, which I didn't love because it implies that this is only psychiatry, and uh, there's a uh, then it would end up reinforcing the problem that psychiatrists and neurologists are doing this separately, although we should do it together. Uh, and of course, there were a lot of neurologists and neurosurgeons there, and they didn't love the idea of calling it interventional psychiatry. Uh, some people like terms like brain medicine or interventional brain medicine. There were pros and cons to that. We ended up voting and deciding that it was a split. Half of the people, literally exactly half the people, voted in favor of brain stimulation. Another half voted in favor of interventional brain medicine. Uh, Initially, we had 11 candidates, then we narrowed it down to two. Uh, and so we said, okay, let's table this discussion for a year. One thing that was unanimous at the end of this conference, uh, well, not yet. One thing that was almost unanimous was almost everybody favored the idea of let's either look into how we're going to start the accreditation process. There's a thumbs up again, uh, or uh, keep thinking about it, then come back to it in about a year. Only two people, I think, said no. We don't think that this accreditation is a good idea. Of course, it was a biased sample because the people who traveled to come and talk about this stuff were probably the ones who like the idea. So that's where we ended after the first year, and the one thing that was unanimous was everybody agreed we should do this again, which I wasn't anticipating. My goal was to do this one time, and then we'll start working towards it if people agree to it. But everybody said, no, 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 no. Let's do this again. We will keep meeting until we figure this out. So again, I was really excited that people cared about so much about that. So we had a second meeting in 2024 in California, in Palo Alto, that was hosted by Stanford. The first meeting was hosted by Mass General Brigham, our institution. Uh, and the second meeting, we hashed out a content outline. We said what is included in this subspecialty and what is not included in this subspecialty. We had a bunch of experts in every sort of component of this stuff uh, come and give talks and say, here's what I think should be in this. Uh, and based on that, like I said, put together this outline. We voted again on the name of the subspecialty. This time it was overwhelmingly in favor of brain stimulation. Uh, and uh, and essentially at the end of it, one of the questions that came up was who should be the society that sponsors this subspecialty. So uh, in order to get an accredited subspecialty, you have to have a society backing it because the accreditation folks want to make sure that uh, the intellectual community isn't just going to dissolve one day. Uh, and so we said, well, there are a lot of organizations that might be interested, like the North American Neuromodulation Society or the Clinical TMS Society or the American Neuropsychiatric Association or the International Foundation for Clinical Neurophysiology. Sorry, another federation, not foundation. Uh, all these organizations have, to some extent, expressed interest in this, or the right, uh, American or the World Societies for Stereotactic and Functional Neurosurgery. All these folks have expressed some sort of interest. But the problem is that if any of them become the primary sponsor, then the subspecialty will automatically become biased in favor of that particular modality. We're doing something unique here, bringing together a bunch of different subspecialties, different disease entities, different modalities. Uh, for example, there's a movement disorder society and an epilepsy society. They also do a lot of brain stimulation. Uh, and so if we spawned it from within the Clinical TMS Society, which of course focuses on TMS for depression, or the North American Neuromodulation Society, which tends to be biased in favor of uh, approaches for pain, uh, then this subspecialty will forever be biased. And so we decided the only way to do this was to launch a new society, which we called the Brain Stimulation Society, uh, whose explicit focus uh, is to uh, shepherd the growth uh, of this intellectual framework for subspecialty training in an unbiased manner to make sure that no one entity gets any more attention than any other. So when there's an accreditation exam, for example, it shouldn't favor one modality or one specialty more than any other. So that's the main goal of this organization. And so we reluctantly launched it because neither Nolan nor I wanted to run another thing. But I think we realized that was the best way to do this. So we've now incorporated. We're working on bylaws. Like we're doing all the uh, logistical stuff required to launch an organization.
Wow. Well, you've got some energy, Shannon. I know you and Nolan have got a lot on your plates already, and you've got a young boy as well, a 9 month old who's keeping you busy as well. So thank you for all your work you're doing for the field. And great that you're bringing together so many different fields, like you mentioned. And something we lack in psychiatry is bringing in the views of neurology and other fields. So I think that's a really, really, worthwhile, you know, uh, uh,
Yeah, it makes a
worthwhile.
difference. So,
It's
yeah,
yeah,
a lot of my key mentors have been neurologists, and I think it was really valuable because I thought I knew how neurologists think based on med school, but obviously, more training makes you better at something. So once you've seen a lot of patients uh, with a particular type of disorder, it'll change the way you think about that field. The same way I do about psychiatry. So it's been very valuable for us to have these collaborations between neurologists and psychiatrists because fundamentally, when you have that training, you'll always think of things you wouldn't have thought of if you hadn't had that training.
yeah. Yeah, and when you do have a particular training, you always need to empty your cup a little bit to take on the information from some other field to open your perspective. So
Yeah, certainly.
really, really, really worthwhile calls there. So that's fantastic. Um, so what next for the Brain Stimulation Society? Have you got another meeting coming up? Are you looking at? Are there any limitations for who can do these courses, or is it restricted to medicine?
Yeah. So for a subspecialty to be accredited, uh, in this contest, you have to be a medical doctor to do it. Uh, and you have to have completed a primary residency in some primary specialty. In this case, we're focusing on people who are psychiatrists, neurologists, and neurosurgeons, but it'll also be open to radiologists or physical medicine, rehab doctors, anesthesiologists, basically anybody who is doing anything that might be relevant. Like it won't be restricted only to those primary specialties. It'll be open to others. We just anticipate that most of the doctors who do it will probably be psychiatrists, neurologists, and neurosurgeons. Um, and it's in the process, however, we'll be creating uh, educational materials. Be having hopefully conferences. We'll have a third Brain Stimulation Specialty Summit this year in Boston, but we'll also have eventually conferences for the field at large. So we don't, because of course it's not going to be only medical doctors that are working in this field. So over time, the society is intended to grow and to be able to incorporate other viewpoints. We need to learn from the researchers, but also from the technicians who are delivering TMS. The field is growing. Uh, and so there might be other accreditations in the future, for example, for people who are not medical doctors. Uh, definitely will be there will definitely be educational programs that are targeted towards medical doctors, but we open to others also.
Great. Great. Fantastic. I know here in Australia we have TMS, which is prescribed by psychiatrists and is reimbursed via a Medicare item with the psychiatrists, but it's delivered a lot through nurses and mental health nurses and psychologists and counselors. So
Yeah, and I think over
yeah,
time
yeah,
that will evolve such that there will be different tiers of TMS or whatever the stimulation modality. Some will be more complicated and sophisticated and will require more intervention from the physician, and some will be uh, relatively simple and straightforward and could be delivered in the community without a doctor being involved.
yeah. Great. So, so Shan, when do you think this will be put in place? Is this something in the foreseeable future, or is it still a few years down the track?
No, our goal is to put in the application for accreditation this year, uh, and so hopefully by next year we'll have a more clear. So the step is first we put in the application, then they either approve it or ask us to revise it. This when I say they, I mean the United Council for Neurologic Subspecialties, which is an organization that accredits subspecialties of neurology such as behavioral neurology, neuro-oncology, neurocritical care, things like that. Uh, and if they approve it, then they'll ask us to submit a list of experts who will help write the exam. So the society is also already working on putting together that list, even though they haven't requested it yet. Uh, and and then they'll write an exam, and once the exam is written, we'll be able to start offering the exam for people to become certified. In order to become certified, you will have to, like I said, number one, pass the exam, and number two, complete an accredited training program. Uh, eventually. But right now, because accredited training programs don't even exist yet, uh, there will be a grandparenting period. So for the first 5 or 10 years, or however long it takes for the programs to proliferate, uh, we'll allow people to take the exam if they just have enough experience in practice without necessarily having to do a training program.
Great, great. Okay, so not far away. I think it's very, it's going to be a great step forward for the field to get this accreditation program up and running and regulate the field a little bit more, which is fantastic because we know CMS is doing such a lot of good for patients worldwide already. So let's regulate it and promote it a little bit more. So I know you've been very generous with your time. One last question: what exciting things are you coming up with at the moment? What sort of research are you working on? What do you think's happening in the field of brain stimulation at the moment that we can? It's pretty exciting for us.
Yeah, so a lot of things are happening in the field where we're trying to figure out how to use brain stimulation better. I think the thing that I'm most excited about outside of our own lab is folks are really getting a sense for how to do mechanistically informed pharmacological augmentation. So you might have seen some of the work on D-cycloserine, for example, uh, which is an NMDA receptor agonist that makes TMS work better. What's really cool about it is that D-cycloserine on its own has no effect on depression and has minimal effects on brain plasticity. But when you combine it with TMS, it makes TMS work better for both depression and OCD or motor plasticity or whatever else. And that's because TMS is believed to work via NMDA mediated plasticity. So when you combine it with an NMDA targeted drug, it makes it work better. That's true synergy. Uh,
We actually just had Jonathan Downer on last month, and he talked about his paper mixing D-cycloserine with TMS. So, yeah, it's
yeah,
very
yeah.
yeah.
Jonathan Downer's been really doing a great job of sort of bringing this to the real world. And before that, Alex McGurr, and before that, Josh Brown did a lot of work on actually showing that it works. I think it's going to have a huge impact. Um, the and so those are some of the things that'll have a big impact. Similarly, figuring out the dosing, things like what Jonathan Downer told you about, or uh, uh, what Nolan Williams has been doing, to taking what we were doing once a day and cranking it up to 10 or 20 times a day. And it turns out it's safe. So uh, uh, we've been drastically underdosing TMS this whole time. Uh, so I think those are the big things in the field. What we're doing in our group, like I said, is finding new applications. So uh, developing the circuit maps via the model that I just told you about. The things that I'm most excited about are using TMS for psychosis, schizophrenia, and that maybe not even necessarily just as a treatment. It might actually be able to prevent the onset in people who are at high risk. Uh, there is, or at least delay the onset. Uh, we're also doing a lot of work on using it for anxiety related disorders. Uh, Working on, to some extent, bipolar disorder, cognitive disorders. So a bit like I said, taking what we've done successfully, deconstructing it, and applying it to other stuff. It's at various stages. Some of these things are at the stages of still like identifying new circuit-based targets, like that's what we're doing for cognitive disorders or functional neurological disorders. Some of them are at the stage of clinical trials. That's where we are with anxiety disorders and schizophrenia. Uh, we're actually bringing this into clinical trials. Some of it's actually already led to successful clinical trials, like in anxiety plus depression. We found that our new anxiety target outperforms the traditional depression target. That's a clinical trial that we're trying to publish now. Uh, Personalization also seems to make a difference. So our group, led by Joe Taylor, recently ran a clinical trial comparing personalized image guided TMS targeting to non personalized regular targeting. And as expected, the personalized targeting does better. Now, that raises the question of do you use it or not? It's a separate question, but it seems to work better. Uh, so what's happening in our group, like I said, is finding new applications and optimizing the current applications. And so I think together, it's interesting. I started lecturing to medical students about this topic 5 or 6 years ago, uh, and actually, not even that. Maybe 3 or 4 years ago, they included a lecture about this topic into the standard medical student rotation. And so at the time, I was telling them, "Hey, this stuff is not going to be on your exams or anything, but we teach it to you because it might become relevant at some point in your careers. This circuit targeting stuff." That was 3 or 4 years ago. 3 or 4 years later, it's already relevant. It's already in use in clinical practice. I didn't expect that it was going to happen this fast, and I think, and that's why I answer your question the way I do, is because I think the reason why I underestimated it was because I was just thinking about what we're doing in our own group, and I said, well, if we're doing this by ourselves, it'll take 15 or 20 years to make a lot of progress. But then folks like Downer and Alex McGurr and Josh Brown and Nolan Williams, all these guys that I'm talking about, have been doing equally exciting stuff, if not more exciting stuff, and it amplifies, and the field grows way faster than any of us would have expected it to.
Yeah, and that's what's great about this field as well. I mean, all of you guys are very willing to talk about your work and share work and just bring the field forward. So, that's amazing. Happy to speak to you anytime, Shan, if you want to talk about any of your work or publicize any of the work that you're doing on to bring the field forward. Please let me know. You're welcome anytime, and any of your colleagues that you think should come and chat about their work, and they're more than welcome. So fantastic. Thank you very much for your time today. Anything else you'd like to leave us with? I'm sure you got to run off to another meeting, I think, don't you now?
Oh, yeah. I mean, I always have another meeting to run off to, but no,
Yep.
this was a lot of fun. Thank you for having me. I think this is a fun discussion, and happy to talk more if there's anything else you want to talk about in the future.
Great. It's been a pleasure to have you, Shan. Thank you very much. Thanks for listening. We hope you got something out of this conversation, and maybe it sparked an interest in developing your skills as a therapist. If you're interested in taking the next step, head to lms.neurocaregroup.com to access a range of professional online training courses in neuromodulation techniques such as TMS, TDCS, and neurofeedback. If you're looking for where to access these therapies, head to neurocaregroup.com to find our network of clinics throughout the world. We'll put these links in the description below. You might also be interested in listening to our other conversations I've had in the series. Be sure to follow our channels on YouTube, Spotify, or however you subscribe to your podcasts and listen to other conversations I've had with a range of experts in the field.